It's on. It's great.
Great. Thank you. So may I start?
Yes, you may.
Okay, thank you. So my name is Luana. I am extremely pleased to be here today. You don't imagine how happy I am. But first and foremost, I want to acknowledge all my colleagues and especially my brilliant Capstone advisor, Dr. Henry Perry, who gave me not the opportunity to learn, but the responsibility to think outside the box. So thank you, Henry, for this. I will present today my capstone, which is about the role of primary health care in this global scenario, the evolution of the concept, and how it is performing now during COVID-19 pandemic in Brazil. The definition of health system, its key components, and the hierarchy to which they obey have been the object of constant discussion since the beginning of the organization of healthcare. The history of human development gave birth to public health, but at the same time, the remarkable advances in diagnosis and treatment of multiple diseases in the past century have led to a gap between medicine and health promotion approach. So as an introduction, I invite you to think about what we want from a health system. As fundamental goals, we want access, equity, quality, and efficiency. More than that, we want stability and resilience, especially in times like these when the entire system is under great stress. But how did we grow to aim for these goals? Do they reflect the standards? If not, what are we missing? And should we rethink the concept of health systems? Throughout our history, the significant health issues that humanity has faced have been concerned with community life. In early civilizations, public health and medical care were based on provision of water, the control and improvement of physical environment, and the relief of disability and poverty. The medieval era shifted public health and medical care courses in a different direction. The confrontation between paganism and Christianity led to the concept of illness being the result of sin. Health was then the consequence of individual behavior with little space for public health development outside monastic communities. The Renaissance saw the emergence of mercantilism. Mercantilism was the economic theory that promoted governmental regulation of a nation's economy for the purpose of augmenting state power at the expense of rival national powers, and that changed public health. The notion of the value of people being intrinsically connected to the state's productive capability led to the recognition of death as a waste of resources that undermined the power of state. Therefore, poor health should be tackled by the state. The age of reason was revolutionary for science and for public health. The development of microbiology and the germ theory changed the scenario. Preventing communicable diseases gained a new, more rational, reliable approach. Instead of solely controlling them through environmental sanitation, public health then was able to control some of those diseases with a variety of new tools, such as vaccination and in an unprecedented scale. Medical technology advanced rapidly in the 20th century. Treatment and cure for some historically deadly diseases were then available in a single pill, a very tangible idea, while prevention slowly became an ethereal concept. Health systems were organized around facilities to offer cure for the ill with little space to prevent them or to promote health. Medical products gave birth to a vibrant industry, turning health care into an over-medicalized system. Unfortunately, the availability of these wonders was far from ideal, and public health and medicine, while rapidly progressing, were gradually growing apart. However, the high costs and the increasing complexity of medical care soon became unsustainable. If the gap between public health and medical care led us to this situation, we needed to find a way to improve population basic health status through an equitable provision of care at a lower cost. That means building a bridge between the idea of public health offering just environmental improvement and medical care being as complex as inequitable. So how then to reconcile medical care and public health? It was not until 1978, with the declaration of Alma Ata, that primary healthcare and universally accessible, low-cost essential healthcare was seen as a central function of a health system. Offering PHC should sustain a well-developed, resilient population capable of coping with health threats. But how does PHC integrate to the rest of the system, and how does it respond to the challenges of an ever-changing world? So Dr. Henry Perry describes a framework to reconceive the foundations of global public health, which he represents using the image of a three-legged stool model. The stool's legs would represent the major support areas of public health, and their strength equilibrium would provide sustainability and balance to public health. The first leg, vertical top-down, disease-oriented public health, would represent the dominant modus operandi of public health in most of the past century. Although major progress saved millions of lives worldwide, that was unfortunately at the expense of the other two legs, whose underdevelopment threatened the balance of global public health. The second leg is service-oriented public health. It represents the essential services whose provision is needed for good health assurance. That includes those services that address epidemiological priorities, possible vulnerabilities, and those that respond to individual needs, even when they do not consist of epidemiological priorities. The third and final leg, community-oriented public health, is the real revolution in this approach. It endorses the empowerment of communities to work in partnership with the system to improve their health status. Although health is seen as a right of the citizen, participation in its production is also a duty of each individual. For Dr. Perry, this model is almost interchangeable between global public health and PHC, but how they relate to each other is still a matter of discussion. So what this capstone proposes is an alternative view of this framework. In this model, PHC is not a fractal image of global public health. Here, PHC is represented by the gray traverses linking these two legs, between being the structure that stabilizes the entire system, connecting them and making use of all components of public health. The addition of these connections improve the structure's robustness and resilience, making it more able to cope with augmented external pressure or even limited internal disproportions. By improving the health status of the population through the unification of the approaches of essential health services provision, basic disease control measures, and education to foster the individual production of health and community welfare under the same scheme, PHC is not placed at the center of the system. Still, it is the fundamental tool for enable global public health to achieve health for all. So now let's take a step back and understand how the pandemic stresses the system. Since there are no medical solutions for prevention or definitive treatment, the collapse of tertiary care is a testimony to the failure of our strategy. The most efficient plan is to prevent the spread of the disease through non-medical countermeasures that represents challenges of efficiency, equitable access, provision of adequate human resources, and maintenance of continuous care. All of them are within the scope of PHC. So this is my lovely country. This map shows the flags of the countries that match our states in size, so you can better dimension it. Our constitution presents health as a right for all, a right of all and a duty of the state. Universal access and comprehensive free care are guaranteed by law, and PHC is the key strategy that we use to achieve these goals. Although facing chronic underfunding, among other problems, Brazilian PHC stands out on a global level due to its extensiveness and robustness, aligned with the evidence of its success in reducing mortality and morbidity in the country. For being capable to simultaneously function as the entry point of care and essential care services delivery actor, agent of surveillance and system overload mitigation, PHC should be promptly involved both in the system's preparedness and response to the pandemic. So these are some of the local level initiatives developed in Brazil. They offer us a glimpse of how the PHC can work if political will and creativity are used, even with suboptimal funding, what kind of impact it can generate, and how advanced this model is compared to other countries where PHC has not been fully developed. Person-centered prevention involves stratifying economically vulnerable families with comorbidities according to a risk assessment tool. Specific actions then are developed to address those individuals, including contact tracing, close monitoring, social support, intensive education strategy, medication delivery, and home visiting. A tailored care plan is designed for the patients based on their risk, assigning them for face-to-face or telehealth consultation. That led to the physical reorganization of the units, allowing them to extend their capacity and help nearby units to deal with increased demand. Due to the high function illiteracy rate in the country, the density and volume of current COVID-19 scientific knowledge production, and the ongoing mistrust crisis, PHC teams are producing their own audiovisual and radio material to communicate with the population. Finally, georeferencing is being used to plan team mobilization in slum areas to help COVID-19 monitoring and also maternal and child care provision. Unfortunately, we are also missing opportunities. In general terms, the lack of an all-level pooled leadership undermines the entire public response. Political disputes have been prevented. Efforts to standardize the definitions of suspected, confirmed, and discharged cases of COVID, including asymptomatic infections, and above all, reporting criteria. But there are some other missed chances. Brazil has one of the largest community health workers programs in the world, but it has been gradually dismantled for the past years due to lack of investment and comprehension of its importance. Their fundamental local knowledge and deep connection with the families they serve are being ignored, and the most unique and powerful tool of our system has been relegated to background. Although tailoring is a crucial tool in public health, we're failing in adapting response to community level. We are also failing in using big data and technological means to improve and speed up investigations. Levels of care are still very fragmented, leading to loss of efficiency in care. Innovative approaches are hardly identified and scaled due to lack of investment in public health science, which means we lose opportunities to implement tailored solutions. And finally, although we do have large experience in dealing with infectious diseases, we fail both in approaching them in a more effective way and using that knowledge to better respond to COVID. So to conclude, this capstone actually points to the fact that we are facing challenges that need more adequate tools. And the proposed PHC framework can reposition the healthcare system to better face these threats. Brazilian case teaches us that although implementing PHC and improving access are crucial factors, they are not enough. An integrated modern approach is key to use this tool as its best. And I think that's all for today. Thank you.
Thank you, that was fantastic. And Brazil is such an impressive and diverse place. In the US, there has been much criticism of overall political leadership with regard to appropriately addressing coronavirus. Would you like to talk about the extent to which President Bolsonaro's leadership in Brazil has or has not made it easier for the PHC model to be effective?
Sure. I think that our issue is that blaming a single person is not fair nor representative. President Bolsonaro is actually the reflection of the population. He was democratically elected, and that means that the way he thinks represents a lot of the ways that people that he rules represent. So the problem is that we need to change education. We need to change how we communicate with population. It's not only about a single person, it's about my country being dilapidated for the past 4 or 5 decades. It takes a toll on us, and it's taken a toll on us.
Thank you. Your advisor asks, how is it that Brazil was able to develop a model PHC program emulated by other countries when many of those other countries have found this to be such a challenge?
Oh, Henry. So I hope he was here since the beginning, so he heard my deepest gratitude to him. But well, I think that we have this new, it's not a new, but our latest constitution was promoted in 1988. And that constitution was the mother of a very alma ata based health system. So it was already, it was something that was happening in South America in terms of the democratic transition of all countries to try to find a way to incorporate those kind of values in the health systems that were about to be born in that moment. So we used Alma Ata Declaration as a basis for our system, and we were able to do that. But although we were really successful on scaling the access to primary health care, quality of it has suffered a lot for the past 2 decades. So we are chronically underfunded, and we need to change that, and also to better integrate primary health care to the system, so it's actually using its full power in terms of taking care of the population itself.
Well, thank you, and thanks, Dr. Perry, for that question. Maybe we'll finish with just one. We always like to prioritize student questions over faculty questions, unless that faculty member is your Capstone advisor. So Bernardo asks, if you were health minister, and maybe you will be soon, how? That's why we train you to go and be health ministers. How would you have changed the Brazilian approach?
Well, I think I heard that from my first day at Hopkins, and I'm listening to the same thing at my final day at Hopkins. So I don't know. Well, I think that the key approach to everything that we do in public health is tailoring. So I think that we unfortunately adopted a so-called European universal solution for COVID response, which is not suitable for our situation as a upper middle income country. As you rightfully said at the beginning, we are a very diverse country. You have everything that you can find everywhere else. We have it in here. So we should be tailoring our response, and we should be using the extremely sophisticated primary healthcare network that we have in here to respond to COVID. Unfortunately, we are responding with a tertiary care, which of course is not going to be enough to take care of that. It's as we say in Portuguese, I don't know the expression for that in English, but in Portuguese, we say that we are trying to wipe an ice cube while it's melting, instead of putting this ice cube into the refrigerator, which is, you know, what we should be doing. So I think that tailoring the approach and using the primary healthcare network that we have, that most countries do not, and the power of our community health workers as well, with their deep knowledge of the community they serve, would be a better fit for our situation.
Love that expression. I wish I spoke Portuguese. That is, that's a wonderful presentation. Thank you for being so thoughtful about these challenges. And obviously they couldn't possibly be any more important, and clearly are meaningful for the US case as well. Randy, okay.
Yep. Congratulations. That was a wonderful presentation. Enjoyed it very much. Very timely.
Thank you.
Thanks so much, Luana.
Thank you, Paul. Thank you so much, guys. Let me stop sharing my
We'll
screen.
turn it back to you, Paul.
So